Hello and welcome to the Acute Medical Teaching Series. We are your hosts, Shifona
and Harrison,
both senior house officers from Salisbury District Hospital.
This will be a 12-part teaching series running over the next 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local medical students.
During this 5th session, we will be talking about the management of NSTEMI. So what is an NSTEMI? An NSTEMI is one of the 3 types of acute coronary syndromes, namely STEMIs or ST elevation MIs, NSTEMIs or non-ST elevation MIs, and unstable angina.
A STEMI is caused by complete occlusion of a coronary artery, resulting in subsequent myocardial injury, and this myocardial injury is measured via a rise in troponin. It presents with characteristic ECG changes, namely a new bundle branch block or ST elevation. An NSTEMI, on the other hand, is a near complete occlusion, meaning that there is still some blood flow. However, there is still subsequent myocardial injury from hypoxemia, and this results in a rise in troponin due to the myocardial injury. The ECG changes you generally see aren't as severe as seen in a STEMI, so we generally expect to see ST depression, new T wave inversion, or a normal ECG.
Unstable angina also represents a near-complete occlusion of a coronary artery, but without the myocardial injury, and therefore there is a non-dynamic raise in the troponin.
Most episodes of NSTEMI are caused by an unstable plaque. If we think back to preclinical medical school, we have plaque formation within the coronary arteries. When the plaque becomes unstable, it releases its lipid-rich core, which causes platelet aggregation and clot formation. This then subsequently leads to occlusion of the coronary artery.
There are, however, other mechanisms to keep at the back of your mind. Medications, such as cocaine, can cause the coronary artery to spasm, resulting in a myocardial infarction. In those with stents in situ, restenosis can occur where the coronary artery narrows. There can also be a supply-demand mismatch within the body. For example, if you have a significant bleed, the bleeding can cause a myocardial injury due to reduced supply to the heart. This is especially prevalent in those with existing underlying coronary artery disease. Some rarer causes include vasculitis.
Next, we'll talk about the typical clinical presentation we see with NSTEMIs. Generally, we'd expect to see chest pain lasting longer than 15 minutes. This chest pain would often radiate to other areas of the body, including the shoulder, the neck, and into the back. The chest pain is generally described as central, crushing, like a weight in the centre of the chest. There is also associated nausea and vomiting, marked sweating, and/or breathlessness. And we know that significant sweating is a common feature due to a high sympathetic drive that these patients experience.
Atypical presentations are more common in older patients, women, and patients with diabetes. This includes presentations such as epigastric pain, indigestion-like symptoms, isolated dyspnea, or syncope. Women are also more likely to present with middle or upper back pain. Risk factors for cardiovascular disease, particularly a history of ischemic heart disease, can also be used in decision-making. For example, diabetes, high cholesterol, hypertension, metabolic syndrome, obesity, and smoking.
Next, we'll talk about the typical ECG changes we see in a non-ST elevation myocardial infarction. We generally expect to see ST depression. We could also see new T-wave changes, in particular T-wave inversion, and we know that in 30% of cases the ECG is normal. A troponin blood test allows us to interpret if there is any myocardial injury within the body. Troponin is a part of the contractile fibres within the heart and gets released into the bloodstream when there is a myocardial injury.
Different NHS trusts use different troponin assays, but here in Salisbury we use troponin T, and this information is only valid for this assay. So normal value of troponin T is less than 13, and this is seen in 99% of the population. A raised troponin can be caused by multiple different acute diseases, including myocarditis, aortic dissection, acute PEs, structural cardiac disease, and AKIs.
A troponin of greater than 30, combined with a good clinical history for an acute coronary syndrome combined with ECG changes, is suggestive of a myocardial infarction. We will then repeat the troponin in 3 hours, looking for any dynamic changes. This is either a rise or fall in the value of the troponin by 20% after serial measurements. If there is a dynamic element, it suggests ongoing myocardial injury and that the raised troponin isn't secondary to another factor, such as chronic kidney disease. Although note, a non-dynamic troponin can represent unstable angina. We know patients with chronic kidney disease generally have higher troponins due to the decreased renal excretion of troponin through the kidneys.
Looking into other investigations, a chest X-ray allows you to look for other differentials such as a widened mediastinum, which can be indicative of aortic dissection, or a pneumothorax. You can also see potential complications of ACS such as pulmonary edema. Looking into blood, we can check the full blood count, Usinase, glucose, liver function tests, CRP and lipid profile to look for other causes that might be driving the chest pain.
We can also perform an echocardiogram in these patients, and it allows us to look for other differentials for their chest pain. For example, we could look for a flap, which we'd see in an aortic dissection. We could look for evidence of fluid around the heart, indicating a pericardial effusion. We could also look for valvular disease. And finally, we could look for right ventricular strain, which could indicate a pulmonary embolism. An echocardiogram also allows us to look for regional wall motion abnormalities, which can be indicative of an ongoing MI.
So let's talk about management. If the patient is not indicated for immediate reperfusion, and we will talk about this later, the key decision is whether to treat with an invasive strategy, so an inpatient coronary angiogram plus or minus revascularization, and conservative management. We can use something called the Gray score, which you can see on the screen. If the 6-month mortality is over 3%, then we can consider inpatient angiography within 48 to 72 hours. If the 6-month mortality is less than 3%, then we should consider conservative management with outpatient angiography.
Next, we'll talk about some of the medications we give when someone is having an NSTEMI. Normally what we'll do is we'll load them on aspirin and clopidogrel. That's aspirin 300 milligrams for one dose, and then we switch them to 75 milligrams once a day. And that's also clopidogrel 300 milligrams for one dose, then we switch them to 75 milligrams once a day. We also prescribe them Fundaparinux 2.5 milligrams subcut, and this is again once a day. However, note, if they're already on anticoagulation, i.e. warfarin or a DOAC, we need to carefully consider the indication for the anticoagulant. In some situations, we don't switch them to Fundaparinux, but in some situations we do, and we should carefully consult guidelines regarding this. We also want to make sure the patient is pain-free, so we start them on sublingual GTN and then escalate to morphine if that's not helping with the pain. If the patient is still experiencing chest pain, then we should ideally be starting them on a GTN infusion. Some patients are also indicated for beta blockers and ACE inhibitors, and these are generally started on the cardiology ward.
Some patients need consideration of immediate reperfusion. Some indications for this, including ongoing or recurrent pain despite treatment, hemodynamic instability, dynamic ECG changes, left ventricular failure, or a life-threatening arrhythmia, so for example, a ventricular tachycardia or ventricular fibrillation. The above features will require a discussion with cardiology for potentially reperfusing the patient immediately.
It's also important to consider the differential diagnosis in these patients. This can include aortic dissection, pulmonary embolism, peptic ulcer disease, pericarditis, esophageal spasm, and costochondritis. Obviously, we'll be anticoagulating these patients, and this can be dangerous in certain presentations, such as an aortic dissection. There's also ACS mimics such as esophageal spasm. Esophageal spasm is very similar to a normal cardiac pain and is often also relieved by GTN, making it difficult to differentiate. Thank you for watching our teaching session today. I'm Harrison.
And Shifona.
Hope to see you next time.